So let's start it slowly. So cesarean section, as we know that it's an operative method for delivering a baby. So let's start with the definition. The definition is this is from your Datta. So it is an operative procedure whereby fetus after the end of 28 weeks are delivered through an incision on the abdomen and uterine wall. Okay, so there are two types, that is primary cesarean section, which is the first time you're doing a section on a woman, and a repeat cesarean section. So subsequent deliveries also by a cesarean section, that would be a repeat cesarean section. So a short history of cesarean section. So obviously nothing has started today or tomorrow, yesterday. So it's been a long time ago. Cesarean deliveries were performed. So this was during the Roman law, where in 1715 BC. So the Romans, they used to perform perimortem cesarean section or postmortem cesarean section just to save the baby. Or if the babies also died in the womb, then they used to section the mother and bury the baby separately and the mother separately. So that was a Roman law, basically. So the cesarean section word that has come from Lex Caesarea, it is not because of the delivery of the Julius Caesar. Okay, and in 1668, there were other more people who started making trials on cesarean section. Francisco reported cesarean sections. In 1876, Porero performed subtotal hysterectomies, and in 1882 was a Max Sanger who first sutured the uterine wall. In 1907, Frank, who described the extraperitoneal method of cesarean section. Then in 1912, Chronic, he introduced the lower segment vertical cesarean incision. All the incisions will be seen them soon. In 1881, Herrer, who introduced the lower segment cesarean section for the first time, but it was not that popular during that time. And later on in 1922, Mundroker, who was a very good surgeon, who reintroduced lower segment cesarean section again. Okay, and now that is what we follow. It is a lower segment cesarean section. So what are the factors for rising rate of cesarean section? Okay. So rising primary cesarean section rates, then identification of the high-risk pregnancies in earlier pregnancies because of a good ANC follow-ups, then repeat cesarean sections, rising rate of induction of labor and failure of inductions, then decline in instrumental deliveries, decline in vaginal breech deliveries, then wider use of fetal monitoring and diagnosis of fetal distress earlier, then fear of litigations and patient's choice. Okay, so on request. So what are the absolute indications for cesarean section? Absolute indications would be central placenta previa, contracted pelvis or cephalopelvic disproportion, what we call, pelvic mass that is obstructing the head to go down, advanced CS cervix, which is not, the cervix is not going to dilate and it will lead delivery. So in that case, it's rather we do a cesarean section. Vaginal obstruction due to atresia or stenosis. Now, relative indications again are cephalopelvic disproportion. Then previous in them you can give a short trial, and if you think that the baby is not descending, then you can take them for section in cephalopelvic disproportion. So that's why it just again brought into relative indication. In previous cesarean section, we do trial of labor after previous section, that is TOLAC. But if the patient refuses to do it, then you have to take them for section. And non-reassuring FHR, dystocia, APH, that is abruption in placenta previa, malpresentations, bad obstetric history, PIH, and any medical disorders like diabetes or heart disease. In diabetes, you're doing because baby is going to be big. So irrespective of the pelvic assessment, it is going to be difficult to deliver the baby. And there will be more likely chances of the baby to go into shoulder dystocia. So rather we do a section and have a safe baby and a safe mother. Okay, healthy mother and a healthy baby. In heart disease, you want to cut down the second stage of labor to avoid the overload to the heart. So that's why heart disease as well. Then common indications, primary gravida, in primary gravida it's fail induction, fetal distress, cephalopelvic disproportion, dystocia, and malpositions and malpresentations. These can be your MCQs. So what are the common indications in primary gravida? What are the common indications in multi-gravida? So previous CS, APH, and malpresentations in multi. So timing of operation. Now either you have an elective cesarean section or an emergency cesarean section. Elective is everything is planned for the patient. So the operation is done in a pre-planned. The operation is pre-planned during pregnancy to give a best quality of care to the patient. So it will be. So we give a and it has to be a properly timed. So the patient's timing, the doctor's timing, anesthesia, neonatologist, nursing, everyone should be available. And all this is arranged well, and then they do a section. So now there are Murat sections also. So some patients do demand for some time that we want a section at this time, that time, and so all these options are also there. So that's why it is elective cesarean section. So when can you do an elective cesarean section? So it is preferably after 39 weeks because everything is good, the mother is good, the fetus is good, we don't need to rush. So we can plan a date, give them a date and time, and we can do on that day, date and time. Okay. So, but in sometimes if there are doubts about maturity, is not sure, then what do we do? Okay. Then you confirm by dating scan. That is the first scan, which was done in the first trimester. So according to that, you take the EDD and we can calculate 39 weeks from then, and we can do any time between 39 and 40 weeks. Okay. Or if that first dating scan is also not available, in that case, we can do lecithin sphingomyelin ratio. If the LS ratio is more than or equal to 2, then this suggests of pulmonary maturity. Or wait for a spontaneous labor pains, and then we can do cesarean section. Okay, so these are a few options if the dates are not confirmed. Then benefits of elective is there's a risk of morbidity and mortality are less because in emergency everything is a HIPAA. Most of you must have attended emergency cesarean sections. The patient is not prepared. The patient's abdomen may not be painted or painted outside. Clipping may not be not have done. So there might be some things which are left and which might cause wound infection and all. So that might increase the risk of morbidity. Mortality in cases of placenta previa abruption. So some patients, some of these patients may be severe anemic, PPH may be the cause. So mortality can be related to that. Then maternal risk, there's a risk of placenta previa and hysterectomies. The chances of hysterectomy increase if there's a other placental abnormalities like placenta creta or percreta. So in future, she might have placenta previa and hysterectomy due to placenta creta or percreta. Okay. So now emergency cesarean section. Emergency cesarean section is the decision has been taken. It is basically an acute obstetric emergency. So in this, when the decision is taken, decision to delivery interval should be within 30 minutes. Okay, so that is DDI timing should be within 30 minutes. So again, your next MCQ. decision to delivery timing interval for emergency section is within 30 minutes. That is not the option in elective section. Elective section, you can take your own sweet time. Okay. Now, category of now NICE guidelines have prepared categories of cesarean section to categorize which type of cesarean section and how much time it should have been delivered. So this is to see that if operative skills are appropriate, to have a watch on how quickly we perform things, and are we able to, is the team efficient enough to move the patient fast and deliver the baby quickly. Okay, so category 1 is the serious category, which is an immediate threat to the life of the baby or the woman. So the decision to delivery time interval should be within 30 minutes. In category 2, there is a risk to mother or the fetus is compromised, but it is not an immediate threat to the life. So the decision to delivery time should be within 75 minutes. And in category 3, there is no maternal or fetal compromise, but needs early delivery. Okay? And in category 4, a planned delivery, that is the elective section, what we call is a category 4 section. Planned delivery to suit the women and the staff of the hospital. Now, preoperative preparations, what do we need to do is have an informed written consent. Okay. Now, what do we mean by informed written consent? The whole procedure has to be explained to the patient in cesarean section, that what exactly are we going to do with her, and what are the complications of the cesarean section. Okay. So, obviously, bleeding, infection is related to all procedures, even if it is a minor or a major procedure. Okay, so need for blood transfusion has to be explained, because there are certain religions in the world who do not accept blood transfusions. That is Jehovah's Witness. These people do not accept blood transfusions. So we had actually seen one case like this. Actually, my professor was operating, and he had a woman with Jehovah's Witness who had a placenta previa, and she refused to accept blood. So all this has to come on the consent. Okay, so need for blood transfusion, blood and blood product transfusion. Okay, and chances of infection post-operative, and injury to the bladder, bowel. These are the surrounding structures to the uterus. So more likely injury to the surrounding structures, right? And so with all these, consent has to be checked. Anesthesia consent also has to be taken separately, which the anesthetists, they themselves explain, and they take it. They look for any high risk in the patients, and they have to explain it themselves and take it. But as a doctor, operating surgeon, we have to confirm that both the consents are in place. And if there is any other procedure to be done along with section, like tubal ligation, so we have to confirm the tubal ligation consent with the patient as well as with the relative. Okay, and the patient is prepared in the labor room with betadine scrub, a Foley's catheter, and obviously the patient has to, if it is an elective planned procedure, NBM. Okay, if it is a category 2 section where you can wait for some time, then you can keep the patient NBM and shift ASAP. Okay, give Rantac and Perinom, that is metoclopramide, half hour to 1 hour prior to the procedure, and shift them. Okay, and blood has to be cross-matched before the patient is shifted, and the receipt has to be kept in the file. So the surgeon has to check both the consent and if the blood cross-matching receipt is there or not, as cesarean section is a major procedure. Now, obviously, you do not have to forget about the baby, because fetal monitoring is important. If it is an emergency cesarean section, then it has to be a fetal distress or some of the other problem which is there. And so fetal monitoring is a priority. So don't forget, and always check fetal heart rate when the patient is on the OT table. Okay, there have been some incidents where the feet, when the woman was shifted from the labor, the heart rate was there, and when she's on the OT table, there was no audible heart rate. Or without checking the heart rate, if you deliver, and if there's a fresh IUD, then who is to blame for? We don't know, right? So we have to continuously keep on monitoring the heart rate, especially in cases of emergency cesarean sections. Okay, and but it's a good practice to always check heart rate before you start the procedure. Then neonatologists should also be available in the operation theatre. Then prophylactic antibiotics are given. So single dose is given on table after induction, after the anesthesia induction is done. Then IV fluids, because if we are keeping the patient NBM, we have to keep them hydrated, right? So we start them on IV fluids, RL or 5% dextrose, 5% dextrose, NS and DNS. Okay. Then anesthesia, preferred anesthesia is spinal anesthesia most of the time. Some patients who are in labor may have epidural anesthesia, so you can use the same thing and use it for cesarean section. Top it up and use it for cesarean section. Epidural is commonly used for painless labor nowadays. So if some women who already are having an epidural catheter in, we can use that, top it up and with higher dose and do a cesarean section. And general anesthesia. General anesthesia, especially in cases of any serious patients like eclampsia, preeclampsia patients, general anesthesia is preferred. Placenta previa, where you need a relaxed abdomen. So general anesthesia is preferred. Where the procedure may take a longer time, general anesthesia is preferred. Okay. And so obviously on table we do antiseptic painting and sterile drapes are put. And abdominal incision. These are the various abdominal incisions which are commonly taken for different type of cesarean sections. Quite common initially, they used to do this midline incision for emergency sections because it's easier to open the abdomen fast with midline vertical incision. Okay, midline. Then there is a paramedian which goes side of the umbilicus. Oops, sorry, I'll go back to that. Which goes side of the umbilicus. This is the pharyngeal incision, which is most commonly preferred nowadays. This is called the bikini incision as well. And it is 2 centimeters above the pubic bone. This is the pubic bone, and 2 fingers above, you take the incision. It's a smiling incision. You can see and it's just at the very bikini line. Then the other ones, Maillard and these are more common with the cancer patients or where you need extensive abdominal to look into. Okay? But now, most of the time, the preferred incision is pharyngeal. Okay? Once you open the abdomen, you cut the skin, you cut the subcutaneous fascia, that is the carpa and the then the rectus sheath, and then you separate the rectus muscles and you open the peritoneum. Once you open the peritoneum, you insert your diamonds. So this is the uterus and this is the bladder. So this is the uterovesical fold. Most of the time, you people are unable to see this during the cesarean section. So this is the uterovesical fold, and this is how we cut it, and then we separate it. You separate the bladder from the uterus, and then you push the bladder down. So this is what you get. Okay, so the lower segment is well exposed now, and this is the common incision what we take all the time. Lower segment transverse incision. Okay, so we extend transversely. So in this incision, the common complication what we can cause is the rupture of the vessels laterally. Okay, then this is the lower segment vertical incision, and so this is not commonly done because it may extend down into the vagina. Okay, so cervix and vagina. So this incision is not commonly done, and there is no bleeding with this incision. So that's why we prefer this incision. Now J shape, definitely no, because you're very close to the vessels laterally, and it is very rarely needed. If the baby is badly stuck, if it is a transverse line or something and you are unable to deliver, then it is a J-shape incision. This is the classical incision, D1, which is commonly taken if it is a placenta previa or central placenta previa or creta or percreta. Okay, so this is the incision where you can just preferred, and you deliver the baby from here. You suture the so more commonly used are this, and in cases of placenta previa, placenta creta, we use a classical. And inverted T, again, if the baby is stuck, this is preferred than the J shape. But we still avoid taking all these inverted T's and all, because if the incision is on this part of the uterus, in subsequent pregnancy, there are more chances of rupture of the uterus. But if you have taken any odd incisions like this, you have to specify it on the discharge card, so that during a subsequent pregnancy, the doctors are more vigilant about the patient, that she needs to come in early. She has to be delivered probably earlier. She has to be given procolysis so that she does not get any contractions, and we will be watching that patient more closely. Okay, so if you have given any odd incisions, then the phalansteal incision, the lower segment transverse incision, then we have to specify it on the discharge card, and ask the patient to keep the discharge card and take it for her next follow-up whenever if she gets pregnant. Now, this is how, so that's a transverse incision on the uterus, and that's the baby delivery in a normal way, right? So once the transverse incision is taken, you put the hand below the baby, flex the head, then the doins is removed, and the baby is, a gentle fundal pressure is given, and baby is delivered, right? You clamp the cord and separate the baby and give the baby to the neonatologist for assessment, and you can apply the Alice and prenatal touch on the uterine edge and then suture it, right? But it's not that all the time you will have an easy delivery like this. So I was fortunate to get some pictures which I could show you. So now this is again a breech delivery in a cesarean section. So you could see that the baby's buttocks are turned to one lateral side. So when you deliver the buttocks, you turn them anteriorly. So the back of the baby should be perpendicular to the tummy, and so spino-anterior what you do it, and then with a gentle pressure from above, you deliver the baby's head. So what does the pressure from the above do is it helps in flexing the head of the baby. So the baby's head gets flexed and it can be easily delivered. So that is how breech delivery is done. Now, if there is any difficult delivery, especially in deep transverse arrest or something, the head is almost gone inside the pelvis. So it's difficult to get your hand down and remove the head. So in that case, you catch up with the baby's legs and you pull the legs. So the baby is going to completely turn and it will be delivered by breech. Okay. Or other method for deep transverse arrest is shoulders, Patwardhan method or modified Patwardhan method. So Patwardhan method is when both the shoulders have come out. Unfortunately, I could not get pictures for that, but both the shoulders have come out. You pull you put your fingers beneath the shoulders, and you pull the back out, and then eventually you'll get the buttocks of the baby. That is a smaller part of the baby's body. So you deliver it by breech there. Okay, that is Patwardhan's method. And in Patwardhan's method, there are high chances of extension of the incisions. Okay, so so the uterine might rupture and all these things can happen. Okay, and in modified Patwardhan's, you deliver one shoulder of the baby, same side leg, then the opposite side leg, For example, if the right shoulder has come out, right side leg, then left side leg, then left side hand, and deliver it by reach. Okay, and that is modified birth organs. In this two things, there are more likely chances of extension of the incisions. So after the baby is delivered, carefully hold the segments, so the lower segment, the lower lip of the incision and the upper lip of the incision, as well as the angles, and inspect for any other extensions. Okay. So once the placenta is delivered, then okay. So this is again one more good picture I had gotten, which is a scar rupture basically. So if it is a previous LSCS and you're doing a repeat section, sometimes you do see a scene like this where you don't really have to give the incision on the lower segment. Baby's head is already come out. Okay, so you just separate the UV fold and you deliver the baby. Sometimes the scar rupture is so bad that the baby is already in the abdomen, and if the baby is already the scar has ruptured, more likely chances of IUD. Okay, so if it is intact and the baby is just in process of delivering like this, you can at least save the baby. Okay, so that's why always check for scar tenderness in a previously sectioned patient when she comes after 7th month. Always keep on checking for scar tenderness. Okay, and scar tenderness, how to check? We have always seen in the clinic. Most of us who have not seen, kindly read in the book and see, or you can see some YouTube videos and do it. Okay, so basically where the lower segment scar is, you press there and see for the expressions of the patient. Engage the patient in a talk, press on the lower segment and see. Basically, scar tenderness checking is you're checking the scar on the uterus, not on the skin of the abdomen. Okay, then so basically in scar rupture, there are more likely chances that the rupture might be irregular. So rigid edges are there, then it is difficult to suture. So if it's not possible to suture it, the last option that is left in scar rupture is that you have to do a hysterectomy, obstetric hysterectomy. But we do try to conserve the uterus. If after suturing also it is bleeding and it does not stop, and if there is a need for hysterectomy, obviously you need two senior obstetricians to make a decision for that. Now, after all good section, now this is a uterine closure. It's not a very clear picture, but once you close the uterus, then you close the abdominal layers. That is, you close the peritoneum. Whatever you have opened, you close it. My professor used to close UV fold also, but we don't close the uterovesical fold. We close the peritoneum with catgut 0. First, we close the uterus with catgut number 1 over here. Most of the people in means other part of the India, they use vicryl also, vicryl number 1. Always use round body for uterus because cutting edges can cause more bleeding while you're suturing. Okay, so always use round body needle for uterine suturing. Then UV fold, if you're suturing, obviously 0 number catgut, and for peritoneum use 0 number catgut with round body. After peritoneum is closed, we close peritoneum we close with continuous suturing. Peritoneum now on peritoneum closure there are two school of thoughts. Some say that do not close the peritoneum. Peritoneum heals on its own within 24 hours. Yes, it does heal on its own, but there are more likely chances. And the other school says that if you don't suture, close the peritoneum, there are more likely chances of increased adhesions in the next cesarean section. So in our hospital, we do follow closure of peritoneum. So we use catgut 0 for closure of peritoneum. After that, the same catgut we use for closure of muscles. We use interrupted sutures for muscle closure. And always, before you close the rectus sheet, always look for any bleeding underneath the rectus sheet, because you've reflected the rectus sheet. There are two vessels which passes, which is the inferior and superior epigastric vessels. So they are direct vessels from major vessels. So that's why you should always look for any bleeding over there. Okay. Then once you've closed the rectus sheet, you subcutaneous fat if needed. If the patient is too obese, then do the subcutaneous fat, and you can take skin with uh, uh, interrupted sutures. We use Ethylon for skin, so it is easily removed and it is a non-absorbable suture. Okay? So whatever we have used inside is the absorbable sutures. And now post-op care for the patient. Okay, so first 24 hours we have to observe, 6 to 8 hours we have to take the pulse, BP, and look for any PV bleeding. Then IV fluids 2 to 2.5 liters in 24 hours. So if there is any blood loss and need for any blood transfusion, that should be assessed and to be given if the patient is anemic or something. And if you think that there was a lot of blood loss, expected blood loss is 0.5 to 1 liter in cesarean section. But if the patient was already anemic, then you will definitely have to. And if the bleeding was minimal also, you will definitely have to assess and give a blood loss, blood transfusion. Then oxytocin, if needed. Obviously, after the delivery of the baby and all, they do give 10 units of oxytocin IM and 20 units in drip. But if extra is needed, give oxytocin 5 units IM or methagen 0.2 milligrams, if not contraindicated. Prophylactic antibiotics are given for 2 to 4 days. Analgesics like pethidine, 75 to 100 milligrams. And if the mother is Rh negative, then obviously anti-T has to be given. Okay. Now, ambulation of the patient, patient can be shifted. The patient can move around if she's willing to. She can sit up, basically move her legs, ankles, move her legs back and forth. Okay, so this why ambulation is important, because if they are still, then there are more likely chances of DVT, deep vein thrombosis. And baby breastfeeding should be established within 3 to 4 hours once the mother is conscious and stable. Now, day one, what do we do? Day one, you start them on oral sips, what you call as a fluid diet. Water, coconut water, any electrolyte water, electrolyte powder you get, so they can mix it in water and have it. Then raw tea. Basically, this all fluids can activate the bowel movements. So once the bowel movements are set in, by the evening they can start with semi-solid fluids, foods like patla khichdi or liquidy rava. So something soupy consistency. Anything that is soupy consistency, they can have on day one. Day two, they can have light solid food. By evening, they can have full meal. And give them some lactulose to have good bowel movements, and so that they can pass the motions quickly. Okay. By day 5, day 6, we do not remove stitches over here on day 5, day 6, but according to your book, they do remove stitches on day 5, day 6. But when I was doing my PG, we used to remove on day 6 and send them home. Okay. So abdominal stitches to be removed and plan for discharge has to be moved out the day. But over here we do day 5 dressing. We check for any discharge from the wound or anything. We do dressing, and day 8 we remove the sutures over here. Now, complications, intra-op complication, extension of the uterine incision, uterine, like we spoke about while we were looking into the incisions, and that may lead to a broad ligament hematoma. Then uterine laceration, lower uterine incision may extend to the lateral and the inferior of the vagina. Then bladder injuries, which has to be sutured in 2 layers with 2 zero-chromic catgut. Then catheter has to be kept for 7 to 10 days if there is a bladder injury. Then ureter injury is very less likely, only if the vessels are injured, like uterine vessels are injured while suturing them. It's more likely to get ligated. Okay, so that is 1 in 1,000 injuries. But if you lift the uterus up and then you suture it. The ureter falls back. So if you see such heavy bleeding, always externalize the uterus, lift it up, and then suture. Okay, so that will reduce the chance of ureteric injury, ligation. Now, GI tract injuries, it is very rare, more common with previous cesarean section patients, like patients who have had a past history of abdominal surgeries. In them, if there are adhesions, then only it is likely that the bowel is come and adhere to the upper part of the anterior abdominal wall. So that time only there will be chances of GI tract injuries. Hemorrhage, uterine atonia, and laceration. PPH we cannot predict. Morbidity is more common with like placenta creta, placenta previa, in which the procedure is extensive and more likely chances of hysterectomy in placenta creta. That's why chances of patient to stay in hospital increase. Now, post-op complications. Immediate post-op PPH, again, average blood loss during section, what we anticipate was 0.125 liter. Patient may go into shock. Now, so that's why we do monitor them strictly for 6 to 8 hours. And with pulse PP, we are checking for PV bleeding also. And anesthesia hazards. So anesthesia hazards is aspiration pneumonia, which is also known as Mendelssohn syndrome. Basically, whatever the GI tract acid is there, it goes into the lungs. It causes lung damage or kind of pneumonitis, okay, chemical pneumonitis. So hypotension, spinal headache are the other complications. Infections are more common, that is endometritis, peritonitis, UTI, abdominal wound infection, pneumonitis, septic pelvic thrombosis after basically endometritis. There is a septic pelvic thrombosis, thrombophlebitis is common, and bladder injuries due to catheter, which is kept for a longer time. So, bladder infection due to prolonged catheterization. So these are common infections. Then intestinal obstruction due to paralytic ileus or mechanical obstruction. Mechanical obstruction is more common with if there are previous procedures done, and there are adhesive bands in which the loop is more likely to go and get stuck. So that will cause mechanical obstruction. Now, DVT in thromboembolism. So always, if the BMI is more than 30, always we have to think for giving them prophylactic Csection. Then wound complications like wound sepsis is quite common. Then serosanguinous discharge of trunk pus is there. Hematoma, dehiscence, and burst abdomen are again another common. Dehiscence, basically all the above layers, skin, subcutaneous tissue, rectus sheath, muscle is opened up, but the peritoneum is intact. And in burst abdomen, everything is opened up. So actually, I've seen one case of burst abdomen, and it can be quite serious. Okay, patient has to be treated very fast, and they might go into septicemia and more likely chances of dying also. Okay, and other delayed complication is secondary PPH. Now, remote complications are gynecological, like menstrual irregularity or chronic pelvic pain. General surgery complications like intestinal obstruction. If post-op there are any adhesive bands formed, then intestinal obstruction or incisional hernia. In future pregnancy, there's a risk of scar rupture, placenta previa, and even scar ectopic nowadays, which I have not mentioned yet, but I'm telling you. Now, maternal and perinatal mortality. Maternal mortality is 0.1 to 1% in case cause of deaths are common cause of deaths in section are hemorrhage and shock, anesthesia complications, infection, and thromboembolism. And in fetal mortality is 5 to 10%. Cause of death are pre-existing asphyxia, are respiratory distress syndrome, and prematurity. Infection and intracranial hemorrhage in breech delivery, if the head gets stuck and is not delivered properly throughout a small incision. So thank you for coming on live.